estimates. So as most of us know very well, so we have huge global families, starting with the DHS and MICS, and including the reproductive health surveys, World Health Surveys, the living standards, part Arab program of family health, Gulf health surveys, the old conceptive prevalence and more fertility surveys. We have such major household survey programs. Those use infant and child mortality estimation process as well as some adult mortality estimation process. So if we just remember what are these main childhood mortality indicators and the estimates on this, we all know that we can calculate under-birth mortality and also child mortality, as well as infant mortality, neonatal mortality, and post-neonatal mortality from such surveys. And we mostly have direct estimates, which are on observed or reported data are used on this survivorship or individual children, including data on their date of birth, survival status, and date of death or age at death for those who have. And we also have some indirect estimation methods, mostly depending on models which were applied some cumulative data. And we also collect some adult mortality indicators from such surveys. The base two are the adult mortality to age 60, from 15 to 60 years, and adult mortality to age 50. These are the two main mortality indicators. And in some surveys, we also try to calculate maternal mortality rate and or the maternal mortality ratio in some rare cases. So, these are the main mortality indicators that we try to calculate. And we also have direct and indirect estimates on adult mortality. So we need to ask some questions if we are using a sibling history to collect information for each birth or pregnancy that the respondent's mother ever had, and usually include some conditions. And in some cases, we have recent household deaths, so that we are collecting a quite simple data for each person that died in the time period, or the following information is obtained, which is the sex of the person, age at death, and date of death. We also have indirect estimation techniques. I'm not going to go too much detail, but by the survey, we have these main indicators that we need to calculate. So these major household surveys are a very big source in most cases, especially if we don't have any the complete or proper registration data and for some other sources. So if we just connect this with how we consider the mortality indicators or mortality, the measures to design the survey, actually the answer is not simple. Because when we are calculating the sample size, or when we are doing the sample size calculations, we are mostly focusing on some important parameters to calculate a figure. And most of the case, we don't calculate a figure, we calculate several figures, meaning that we make calculations on several indicators, parameters. But we are not only considering this parameter approach, we are also taking care of the available budget for the survey. So it is both technical, at the same time, some logistic process to calculate. But if I just go back at technical part, which is the calculation of the sample size, first of all, we need a parameter, and then we need a level of precision required. In the screen, you see the mixed approach on the right side, the formula, which is denoted as RME, this relative margin of error, which is actually the half of the confidence intervals, one side to left to the right. And of course, we also have the design effects value and response correction, and also some average household size to calculate these figures. I'm giving this formula because I'll also give some examples, some number examples, and connect this with the mortality approaches. So in most cases, we are choosing an important indicator or indicators that yield the largest sample size. And if it is satisfying us for the other indicators, we are generally taking care of this size and design the survey. So, but that doesn't mean that, given that the mortality is a rare event, the infant mortality is set, or the rarest one, the maternal mortality ratio, in most of the cases. So these are not the candidates for the key indicator, because huge sample sizes are required if you are taking care of these indicators are the base for sample size calculations. In most cases, you need tens of thousands of cases or households to satisfy these indicators. But that doesn't also mean that we are not calculating these measures from the surveys. The surveys calculations are not based on them, but the survey results are also given by taking care of this mortality indicators, although they have larger sampling errors, meaning that they have wider confidence intervals compared to other indicators. So because the sample sizes are relatively small to calculate mortality indicators, as I said, we have higher sampling errors around child mortality estimates. And if you look at the DHS or mixed reports, you will see the sampling errors for such rates, mortality rates at the end of the final report, and you can have an idea of this. So we have a challenging situation. We are taking care of rare events, statistically rare events. And most of the time, when we calculate an infant mortality or under 5 mortality, actually, in order to increase the sample size and reduce the sampling errors, we calculate these indicators for periods, meaning that we are calculating something for most of the time last 5 years, especially for the national ones, and even for some sub-national ones, we calculate the infant mortality for 10 years for most sub-national estimates. So what this 5 years meaning that it is referring a date which is almost 2.5 years prior to survey date. So if I am giving a 5 years period mortality estimates, meaning that I am referring almost 2.5 years back to the survey date. This is one point that we need to discuss with the estimates from the surveys. The other is we always focusing on the subgroups of the segregated groups, such as regions, education, even urban, rural. We can have estimates, but this is increasing the sampling error. So for this disaggregated, the classes like socioeconomic characteristics, urban, rural, region of residence, education, income, wealth, quantize, ethnicity, we should be aware that the sampling errors are increasing, and we should use the figures carefully. And of course, as in the many indicators, we also have some issues on the missing data. So we need to calculate, or we need to collect some specific, mostly date-related the information. So we need to also handle the missing data. They either exclude the cases with missing data, or we need to apply some imputation models or processes to take care of this. So why I'm telling this, this is becoming more and more challenging. And if you look at the DHS, for example, regulations, the DHS is not presenting the results if they are based on less than 250 observations, unweighted observations, or they are giving the results in parentheses, meaning that please use these figures sensitively if the rates based on the 200 to 500 unweighted exposed persons. So this is really a challenging process, and we need some significant number of observations to do that. I just made a simulation on 2 different approaches to calculate the infant mortality level, but we can also consider this as some other mortality level. And I assume we have 5 countries. The first one has a infant mortality of 5 per 1,000. The last one is 200 per 1,000. So globally, we know that the figure is around 37 per 1,000. So most probably the first 3 countries are kind of representing most of the countries in the world. So if I'm looking for an RME level of 15%, meaning that my confidence intervals width is my 50% of my point value. So I need to go almost 150 150,000 households. So if I have a very common or high value of even mortality, then I can fix this with less number of observations. But we know that there are very limited number of countries having this figure. So this is the one approach. I fix the RMU value. In the second scenario, I fix the sample size. So I have to say that I also fix some other inputs for the sampling size calculations, which is not the actual case, I have to admit, because once you have the lower fertility, that meaning that you have lower household size and you have lower response in most cases, and the proportion of the children in the total population is kind of also low. But these calculations are also showing that if we fix the sample size, then our precision or the tolerance is also increasing. So I'm just numerically showing you how the sample size is depending on if we just focus on these indicators as the base. So what can we do? So we all know that this is a great thing, thanks God. So we have low and decreasing mortality rates as well as fertility rates. But this is really challenging from the statistical perspective to have adequate number of observations on classical sampling approach. So before the discussions on this webinar, as I have some experience to apply an oversampling strategy, which is developed by a mixed team, and you can also find in the references, even a working paper also share. Mixed using an oversampling strategy, especially in the low fertility countries, in order to have more children in the sample. So how they do this, they have some EA level information so that they can just determine during the listing whether the household is with under 5 children or not. So then we are giving a higher chance to be selected for such households. And afterwards, we adjust it with the recalculating the weights. By this way, we have some impact, some significant impact to increase number of cases from the 1.5 times to 2.8 times in some countries. Of course, this has some other issues, but I was just thinking that can we kind of adapt this to household surveys to measure the especially adults or the overall mortality, and can we do a kind of a screening during the household listing prior to the data collection and ask households or try to collect information whether any deceased member in the recent period. We can also discuss what is the recent period, a year, the last 2 years, or last 6 months. So this is just an idea from me. So this oversampling can be applied. And I believe that if the oversampling of mixed strategy be applied, it's already increasing the number of children, which has a direct impact also on the mortality cases. But this can also be effective for the adult mortality, maybe not only the low fertility the countries, maybe even in moderate or even higher mortality. Of course, I have to say that there are several risks, and we need to examine or maybe make an experiment on this, or maybe already there are some examples, which I don't know. But it's really becoming the listing operation very complex. And in most cases, you may need to collect the data from the secondary source of data, such as neighbors or some proxies, which may not be unreliable. There might be, of course, misclassifications because of the deaths. Is that really the member, the age issues, and others, which increase the design effects. And of course, this will also break the general balance in the population, which you need to readjust with calculating some complex weights. And this variability in the weights also affecting the design effects. But I think that it is really worth to discuss to an alternative to deal with this decreasing rates and also the rare events. So when we look at the general trend, we really see that we have a significant drop in last 30 years. So it has dropped 60%, but still we have some regions where we have almost 75 deaths per 1,000 lives in Sub-Saharan. So the issue is really challenging. We need to measure this. And we have an additional issue with the pandemic. According to the did some studies, which has a modest direct impact, but there might be some indirect impact on the mortality. So it is really worth to study. And given that we have excess mortality due to pandemic, can we kind of consider this COVID impact on these issues? And can we adapt the household surveys to measure this declining mortality, and as well as can we measure this excess mortality? This is the challenge I believe that today we'll be discussing during the panel. And I assume I briefly remind you the main indicators and the sample size considerations, and also an alternative idea to deal with. So this is over from my side, and I thank you for listening to me.
Thank you very much. Thank you very much, Sinan, for this excellent presentation, giving us an overview of the current methods of sampling, as well as suggesting some leads for modifications or improvements, and putting this whole discussion in the context of long-term and short-term mortality trends that might be at odds with each other to some extent, given the pandemic context of the past 2.5 years. So right now, what we're going to do is we're going to bring in our other panelists. So 4 panelists. If you are able, please turn on your camera, the 4 panelists, so that you can join us virtually. And we're going to have a discussion that builds on some of the issues raised by Sinan's presentation, structured in kind of 4 rounds of questions. So in the first round of questions, I'm going to ask you guys general questions about your current activity in household surveys. In the second round of questions, we'll talk about issues of coverage, selection of respondents, and non-response, and how that may affect our ability to learn about mortality in the context of a pandemic. Our third round of questions will deal with issues of sample size and statistical power, which are extremely salient, as Sinan's presentation pointed out. And in the fourth round of questions, I'll give you an opportunity to mention what you think might be some innovations in sampling that might enhance our ability to measure the role of the COVID-19 pandemic. Okay? And after that, we'll open up after those 4 rounds of questions, we'll open up to the audience for more questions. So my reminder for the panelists is to keep your answers relatively short and snappy, so that we can go through all this ambitious agenda. Okay. So let me start with James Muwonge. So James Muwonge is at the Uganda Bureau of Statistics, where he's currently the head of surveys. And James, I wanted to ask you in that context. So the Uganda Bureau of Statistics is currently conducting or planning a DHS. After having completed population-based HIV impact assessments last year. And in that context, I wanted to ask you, how has the COVID-19 pandemic affected your approach to sampling in those various household surveys that you've been implementing?
Thank you, moderator. Good morning, good afternoon, wherever you are. My name is James Muwonge, as I was indicated. I've just currently moved to a new directorate, which is in charge of methodology and statistical coordination, but I was heading household surveys for over 15 years. In terms of going to the question, yes, DHS, we are currently undertaking a DHS. Specifically in terms of sampling, I think the COVID-19 did not impact it, because as far as sampling is concerned, but it impacted field operations greatly, because we had started training when we went into a lockdown. So again, when we resumed, training, again, we had to go back into the lockdown before we could go to the field. So we've had training almost 3 times to go to the field. So the impact was more in the operational side rather than in the design, actually, because the design had actually been finalized before COVID. And so what we are trying to do is to implement the design that, of course, we had done with with a few modifications there, but the sampling, the frame, the considerations, of course, as you may be aware, working with the ICF, there wasn't much change that occurred to the actual sample design of DHS. It's the usual design. And so the effect was in other areas, because as I said, we couldn't simply continue with the data collection. So we actually, DHS has delayed by 2 years. So we are now implementing it instead of having maybe completed it somewhere in 2021. So, so generally, in terms of the approach, we maintain the same approach as before COVID, designs. Thank you, moderator.
Okay, thank you very much, James, for relating this experience. So let me turn to our next panel speaker with Heoi Cheng from the United Nations Statistics Division, where she's the coordinator of the Inter-Secretariat Working Group on Household Surveys. And before she joined that position in September 2019, so right before the pandemic, she led the program on international migration statistics at the Statistics Division. She has also worked on various statistical areas, including gender statistics, censuses, and CRVS, and she holds a PhD degree in statistics from the University of Florida. So, Heoi, let me ask you then, in your work with the Inter-Secretariat Working Group, you interact with many countries implementing household surveys throughout the world. So are there other ways or any ways that sampling strategies have been adapted or modified in response to the COVID-19 pandemic?
Thank you so much, Stefan. Great to be part of the panel. So what we see really it's not really about modifying sampling strategies. Sometimes, like James had mentioned, is all the frustrations that we see how insufficient our survey infrastructure was pre-pandemic. So we all know that at one point during the pandemic, I think around May, June 2020, almost all countries had to stop fully or partially their face-to-face interviewing. But then there are countries that took very different approaches depending on how ready they were by the time we were all into the pandemic. For example, some countries had been already experimenting with different frames, with different data collection mode pre-pandemic, and they were very much ready when the pandemic hit. They quickly moved to fully remote with telephones or web surveys, and then they have a frame that's ready. So nothing was really impacted on, and that not greatly impacted on. Then there's another group of countries that have done. They weren't really experienced with remote data collection, but they have been running panel surveys, longitudinal surveys regularly. And before the pandemic, they had a survey just completed maybe 6 months ago. And then in those surveys and telephone numbers were asked to household members. So for example, I remember one of the LSMS survey in Malawi, I believe they were telephone numbers was asked, up to 4 numbers were asked. So countries, they were able to go into mobile data collection right away. But the last group of countries, it's really, there was no frame, no contact information, but there was so much pressure to collect data during COVID. A lot of pressure, so they had to rely on RDD, random digit dialing, or a list of phone numbers somewhere. Could be from a good administrative data source, but most time it's really from a private company, and we actually have no idea how representative, how good the list is. So this has really created a lot of challenge for the countries. The other thing I saw for the more developed country is COVID really make people think how we have left vulnerable population groups behind. So from that end, there has been a lot of movement into multi-frame work, building better frames, so you can basically find people from different angles. And this is what I've seen from the experience of countries. Thank you so much.
Thank you, and we'll get back to the issue of vulnerable groups and how to include them in a survey in a little bit. So now let me turn to you, Etienne Gignoux. So briefly, Etienne joined Médecins Sans Frontières in 2001 as a water, sanitation, and hygiene specialist. And he then became an epidemiologist and joined Epicenter, the epidemiological unit of MSF in 2013. And he's based in Geneva, where he provides epidemiological support to MSF operation. And he works in particular on epidemics like COVID-19, but also cholera, Ebola, malaria, hepatitis E, as well as on population displacement. And Etienne, I wanted to ask you, so your work on household surveys at MSF has often taken place in areas and populations that are underserved, hard to reach, or facing acute health crisis. So could you tell us a bit more about how your approach to sampling in such settings differs from the typical DHS and mixed methodology that Sinan presented earlier?
So hello everyone. Yeah, so we do generally a mortality survey, and for the COVID epidemic, we also did 5 population-based mortality and seroprevalence survey. So the difference with the mix and the HIS, as presented before, is that first we don't cover an entire country. Normally we try to cover an area where we want to act. So in this 5 survey, except in Cameroon, where exceptionally we cover the entire country, we did a survey in DRC where we cover 2 health zones. We did in Lubumbashi, we did 2 communes in Abidjan, 1 commune in Khartoum, and 1 refugee camp in Kenya, in Dagare. After we use the common PPS, section of cluster with a probability proportional to the size of the village or neighbor that we target. And inside this cluster, we use spatial sampling based on satellite image. We randomly select points that fall on the roof of the cluster targeted. But for the COVID, what's our main issue was that we wanted to have first to estimate the excess mortality, and in parallel to understand the circulation of the virus, of the SARS-CoV-2 virus. So we nested in our mortality survey a seroprevalence survey in a subsample of household. And for the mortality, we used a recall period that will include a pre-pandemic period that would serve as a baseline, and we compare with the mortality during the pandemic period. So like 12 months before the start of the pandemic, and from the survey, all the survey occurred in 2021, from the survey to the start of the pandemic. So with that, we could try to identify an excess mortality link to the pandemic. The problem we face is that we did observe an increase in deaths during pandemic compared to pre-pandemic. The difficulty is to link that directly to the COVID. So in our questionnaire, we ask about comorbidities, symptoms before death, cause of death reported, health seeking access, to try to have a better link. But still, we observe an increased mortality that is partially due to the effect of the virus itself, but also partially due to the side effect of the pandemic in general. And thank you.
Thank you so much for this description, Etienne. And final panel participant, so Jeffrey Eaton, who's a senior lecturer in HIV epidemiology at Imperial College, where he develops new methods to characterize HIV epidemic trends and the demographic impacts of HIV epidemics in Sub-Saharan Africa. Jeff is the co-chair of the Secretariat of the UN-AIDS Reference Group on Estimates, Modeling and Projections. That's a global scientific advisory group that provides scientific and technical guidance to UN-AIDS on the data and methods used to develop global HIV estimates. So, Jeff, now you're primarily an end user of survey data on mortality, and it would be great if you could tell us a little bit more how you use those data collected by household surveys to estimate HIV-related mortality.
Yeah, thanks very much, Stefan, and thanks, Sinan, for the great presentation earlier. So we've heavily relied on household survey, in particular in Sub-Saharan Africa, to track the trajectory of AIDS mortality in Sub-Saharan Africa in general population epidemics. And survey data have really been, for reasons I'll describe, one of a number of different sources and strategies that we've used to triangulate and come to what we think is a robust understanding of AIDS mortality in Sub-Saharan Africa. The way that we use the survey data is we primarily use the sibling history or the maternal mortality modules from the DHS surveys and a few of the mixed surveys that record information about deceased siblings and the age at which your sibling was deceased. And so the sibling histories give us direct estimates of age-specific mortality over roughly the past 10 to 15 years before the survey for the age ranges of adults that are within the ages of siblings of survey respondents. So, you know, from age 10 or 15 up to 55 or 60. I think that, and so the general strategy is of course, all we get from that is all-cause mortality. But HIV in Sub-Saharan Africa has really been a unique mortality event and has some advantages for the ability to leverage all-cause mortality data to understand the excess mortality from AIDS. So firstly, HIV was a very large excess mortality shock. It grew exponentially very quickly and was sustained over a period of time. And then it also reduced very quickly after treatment. It also affected age groups that had otherwise low mortality. So we could very clearly see the signature of HIV mortality within the 15 to 59 age group that we have mortality about. And so the strategy for estimating excess AIDS mortality was essentially to compare the observed levels and age patterns of mortality with pre-pandemic, pre-HIV pandemic mortality levels that were estimated either using the historical data, because we get data going back 10 or 15 years from the sibling histories, or using model age schedules of mortality. I think another component of that's been useful is to combine the survey data with model-based strategies for analyzing the survey data, which allow us to smooth out age patterns and time trends, that allow us to better leverage the quite small counts that we get in individual cells, and secondly, using models to adjust for reporting biases, in particular recall biases and heaping that are a feature of the survey data in order to reconstruct the patterns. And so I think, just to relate that to maybe how it relates to COVID, in a sense, we were quite lucky with HIV because it, in a sense, affected age groups where we can very clearly observe excess mortality with the sibling history data. But the survey data do give us very, very sparse data on mortality at older adult ages, and where those data are reported, they tend to be more susceptible to reporting errors. And so I think that's a particular challenge for translating some of the stuff we've done on HIV to COVID, perhaps.
Okay, thanks so much, Jeff, for this overview of your work. And so now I want to shift to a topic that we've already partially touched to, which relates to coverage, selection of respondents, and non-response in those surveys. And briefly, Sinan, I wanted to get back to you to ask about some of the rules in presenting mortality rates for subgroups in surveys. where you mentioned, you know, that below 250 cases, for example, we do not show these results. So could you tell us maybe just a little bit more how those rules were established and what might be some of the statistical reasoning behind it?
Sure. Yeah, we have such rules not only for the mortality indicators, but also in general, especially for the marginal estimates in DHS mixed or similar surveys. Actually, these rules are generally depending on some the parametric estimates. So as we all know, if the number of observations are less than 30, so we cannot just directly use some parametric or normal approaches. So that's why if these marginal cases are less, so we don't want you to present such estimates. So if I just convert this to the mortality ones, in the mortality ones, actually, we are not directly using the personal information. We are using more complicated things coming from the birth history called exposed or number of persons or number of days, something like that. So the observation there is not actually one unique person. Actually, his or her 5 years or 10 years kind of exposure to the death, being alive or death, something like that. So these rules are coming, especially for mortality estimates, to have such parametric estimates, first of all, to share, then to share, but to use in sensitive way, then or just to use directly. And this is not the only condition we take care in the surveys. I will start to use the data by looking the sampling errors. So if I see some huge relative errors or big confidence intervals, so I wouldn't use that report or figure directly. That is kind of my rule. But for mortality indicators, as statisticians or survey experts, we are more kind of flexible, because it's a very rare event, and then you cannot kind of consider the same rule like conservative use, which is 70%. On the other hand, you have some infant mortality around 10 per thousand, which is only 1%. So that's why we develop such rules, just kind of to the readers at least be aware of how to use the numbers. Well,
Thank you so much, Sinan. So now, following on this issue, Jeff, let me ask you: in your work on HIV epidemics, are there particular population groups that you worry are underrepresented, excluded, or even less likely to respond in household surveys? And how does that affect the estimates of mortality you were able to produce?
Yeah, I mean, I would, in a sense, say all of the population groups. One of the features about the household surveys or the sibling history data is that we don't have any specific data about the deceased or the characteristics of the deceased. And so really all we're able to glean from the sibling history data are overall population, total mortality, and we don't have any specific mortality about more vulnerable populations who might be more at risk for HIV, who might be more at risk for not having good access to treatment or challenges adhering or staying on treatment. And so any information that we do have about specific population groups comes from specific studies. For example, we rely heavily on population cohort studies or triangulating that from other information such as treatment coverage. And so I think ideally there's more that we could do to leverage household surveys to get more detailed mortality information, but I also think it's a good example of where it's important to triangulate what we're able to say at the population level with household surveys with other data sources that we might pull in.
Thank you, Jeff. And so, Etienne, kind of a similar question. In your work on mortality during epidemics and other crises, you have concerns that some affected groups in your target population are less likely to be contacted or to participate in the survey. And if so, are there specific measures that MSF has implemented to try and address these issues?
Well, in general, it's more the access to population for us that it's an issue, and often due to security reasons. So we did use phone survey, for instance, during the Ebola epidemic in Monrovia in 2014, because we didn't want to expose our team to risk of infection. We also used phone survey in North Cameroon in 2017 in an area with a high insecurity due to the conflict in this area. This proved to be useful, but it's really challenging to get a good list of phone number. We have also some logistic issue when we do a survey in the remote place, for instance, in DRC, in Congo. Then we have to use all the transport means available, but normally we succeed. We use boat, pirogue, train, whatever, plane. For COVID, however, we didn't have this, for the 5 survey, we didn't have this issue, except for one in Dagale, in the refugee camp. We couldn't directly go to see the household ourselves because we have a history of kidnapping in this camp. And then we use a community health worker network. So it was a big team with limited skill in terms of survey, but then we simplified the sampling methodology. We just did an exhaustive sampling. We sampled all the camp. And what we use also is capture or recapture to try to identify the deaths collected during the survey and to match with the database of deaths at hospital. However, that didn't work very well because of the problem in the 2 databases and the difficulty to match the deaths from the 2 databases. But capture recapture is for us, it's something that we really want to explore, and we did also for Ebola in Monrovia again. That give us a good estimation of mortality that we don't see. In terms of refusal, normally for mortality survey, we have very, very low refusal. So we have access to the population quite easily, maximum 5% of refusal. But in that case, for COVID, the mortality part was not a problem, but the household where we asked seroprevalence, then we had very high refusal for the test that included a fingerprint. We had up to 50% of refusal for the seroprevalence, but not for the mortality part. And thank you.
Okay, thank you for this experience. And so now let's try and see if James, in Uganda, there have been also specific efforts that have been made to increase inclusion and participation of some population groups or geographic areas. And if so, could you describe some of these efforts from the Bureau of Statistics or other groups?
Thank you. Yes, I think in Uganda, as you may be aware, I think we are home to over 1 million refugees, and they keep coming in up to date, even as we speak. They keep coming in from DRC and other countries. So we have this group of people whom we are previously excluding from the household surveys because it's not a normal population, it's in a settlement form. But given that they have been here for a very long time, we have had refugees for over 10 years or 15 years. So what government decided is to integrate them in their planning processes. So we wanted to make sure that we don't come up with isolated studies that are specific to refugees, but to have a survey like a DHS that treats, for instance, the refugees as a separate stratum. And so that's what we've been doing. Of course, it's a different framework together, but the idea is we conduct it more or less at the same time, and try to come up with the aspects of PSUs that we can be able to attach probabilities to, and then try to come up with samples and be able to compare, so that when we do, like now we are doing a DHS, we have finalized the design. We're actually working on the design for the same DHS, but in the refugee settlement. And so the idea is the results should come around the same time, so that whoever wants to look at the refugees, they look at it as we have the common designs, more or less similar, and the results to some extent will be comparable. So that is a group that we are previously ignoring, but increasingly, given the influx of refugees from South Sudan, from DRC, it has become, inevitable that we have to integrate them in our survey data collection processes. Thank you, Chair.
Thank you so much, James, for this mention of these efforts to include refugees. Let me ask you briefly a quick follow-up on this. Then, do you formulate specific objectives in terms of precision of indicators for this stratum independently, or how do you kind of calculate sample sizes for this stratum more generally?
Yeah, okay, of course, we don't cover all the indicators as they're in the DHS, because there are a number of aspects that you have to consider. But we work closely with the UNHCR, okay, and then try to get indication of the numbers that are in the different settlements. Of course, there are those who come in and they are still in the reception centers. Those ones are kind of excluded. We deal with those who have been settled, and they try to identify some of the key indicators that are similar to DHS, but not all of them. Okay. And ideally, there are issues to do with the productive health aspects of mortality, yes, especially the infant mortality issues that are captured. But again, there are discussions where they want us to include as many indicators as there in the DHS, but there are many, issues that come into play, because these are refugees. The language they speak, there are different languages. There's French speaking, there's Arabic, and so on. So getting, operational, when you look at all of these, I think it becomes a bit tricky to include so many, especially where some of them are so sensitive, and they may not be able to get the interviewers who are actually able to speak the language to communicate to, especially the women. So we try to limit the indicators, but that is to ensure that those that we capture are comparable, more or less, with the traditional DHS. Okay.
Thank you, James. And so now, Hoyi, let me ask you, since you have a vantage point on this from the Intersecretariat, what are some of the efforts to sample more vulnerable populations that have been tested or promoted, both since the adoption of the SDGs and also whether there have been renewed efforts to sample such populations since the beginning of the pandemic?
Thank you so much, Stefan, for your question. So I've mentioned earlier in my response to your earlier question on the integration of different frames, that countries are really more developed countries are really pushing towards that, because they realize that it's still not sufficient, their frame, to capture the most vulnerable population group. This has been mentioned earlier by other panelists as well. We are also working to support the SDG monitoring. We're also working on sampling guidance to better capture vulnerable population groups. And then we see a lot of challenges, for example, that really goes beyond households, what we are usually familiar with. For example, homeless as one of the vulnerable population group, and drug users, prisoners, that really is outside what we used to think about what household survey is about. So we have to go really beyond the traditional frames. And the other thing we see during COVID is actually most of our countries were really how do you call it, adaptive and really quick, innovative in taking remote data collection with phone surveys or some with web surveys. But we do see that because of the telephone penetration, and challenges in some of the countries, we are leaving actually a lot of people behind. So our group and the Intersecretariat Working Group on House Survey is currently finalizing a guidance on how to assess the bias of survey data for those surveys carried out during COVID time, and how to reduce the bias. We understand it's hard to reduce or eliminate it completely, but how do we reduce the biases potentially by benchmarking, by compare with other data sources, by triangulating. So we have a draft, but we're going through a review at this moment. If any one of you like to provide comments, it's open for suggestions and comments. So lastly, I would like to make it overall for the SDG monitoring, and I see that it's going to be very helpful for household survey as well. So it's this data called community-driven data or citizen-generated data. So it is driven a lot by local communities, by civil society organizations, and they have been collecting a lot of data. They're trying to really feed them into the official statistics circle, but that has been very challenging with the challenges in working with non-official data, and also quality considerations from the official national statistical offices. So we're trying to really incorporate them into our framework, and they will also be very helpful for us, for household survey people, to reach out to those we do not usually see in our survey operations. So our UNSD is organizing an expert group meeting in October this year to really put this kind of data, that type of data, into a framework, conceptual framework, and how to define it. How do we really move forward together with our partners from different communities? So I see this will be a strong push to really get the vulnerable population group in the picture. Thank you.
Thank you for this overview of global strategies. So now let's turn to our next theme, and the crucial theme of sample size and statistical power, and the attached challenges that have been well laid out in Sinan's presentation. So let me turn to Jeff first, and let me ask you, Jeff, in your work on HIV epidemics, are the available samples that you may get from household surveys sufficiently large to assess HIV-related mortality or all-cause mortality, as you mentioned, working on? And in that context, what are some of the patterns that you can measure, and what are parameters or trends that you cannot measure and wish you could from such survey data?
Thanks. So I think that in broad terms, the sample sizes are large enough in the context of hyperendemic HIV settings where there's a very clear signature of HIV on the overall mortality. Or I would say that the sample size hasn't been the main constraint or the main limitation. For the age groups and time periods that these surveys cover, we are able to see very clearly the age pattern of the distortions in the age pattern of mortality that was wrought by HIV, and to see the increase and decline in mortality with the sample size that we have. I think that the limitations of the surveys are probably more a factor, both in terms of reporting biases and recall biases that need to be adjusted for, that introduce inevitably an amount of uncertainty in the interpretation of any levels or trends that come from the data. Secondly, in the current context where AIDS mortality is relatively low and the margins that we're seeking to quantify are smaller, the value of the current household surveys is less because we can't as credibly differentiate excess mortality when the margins are smaller. And so I think that further use of surveys for specifically quantifying AIDS mortality will require specific data about cause of death and the characteristics of the deceased. And so I think that's really where the main limitations come in, as well as, of course, the age ranges that the surveys don't capture data about. So in particular, adults above age 55 or 60 is largely a data-free zone at the moment.
Okay, and just to follow up quickly on this, how do you think those strengths or challenges of the surveys extrapolate to the COVID-19 situation? If we were to take your lessons from trying to assess HIV mortality and take this to the COVID-19 pandemic?
So I think that the ability to triangulate data over a time series is very important, and so any additional information that we could add into the surveys to give reference points or be able to identify biases. So for example, we've largely relied on the sibling history data, which give a long retrospective time series. Some surveys have also asked about household deaths in the past 12 months, and we found those data less useful in many cases. In particular, the mortality rates, that direct mortality rates from that question tend to be in household surveys tend to be systematically higher and in quite a variable way, and we speculate that that is due to telescoping effects, likely, and so I think that adding and also one of the advantages of that question is it does include older adults, but age reporting can be quite variable, and so I think that any sort of anchoring questions to identify when the death occurred relative to an event of interest or a time period of interest will add a lot of value to what we can get from for the COVID context.
Great, thank you, Jeff. And now, James, I wanted to ask you again about your recent experience with surveys in Uganda. So, did mortality rates figure somehow among specific objectives in post or during surveys that were conducted during the COVID-19 pandemic? Did the COVID-19 pandemic influence calculations of sample size and target sample size in any way? And for example, did you try to power your survey so that maybe you could detect a specific effects of the pandemic on recent mortality trends? And more broadly, how do you see survey collection on adult mortality to be integrated into the household survey system in Uganda?
Okay, thank you. Ideally, the surveys that we have done and which we are doing now, some of them are ongoing. We did not, there was no so much influence of the need to factor in the effect of COVID into it. In terms, generally, what drives the inclusion or exclusion is really more what the users actually demand. And in the current DHS, yes, there is a module on mortality that is there for given, I think 15 to 49 for the given age groups. But just as it has been, but it is not that it has been included specifically because of the COVID effect as such. And but what we've been trying to do is, and this is something which we have been trying to capture, to see how we get also adult mortality generally, because as health systems improve, the chances of dying or mortality becomes a rare occurrence. And so what in a normal survey sample, we are likely to get few observations. Now, in the DHS arrangement, what we do is to identify all those households, the sampled households where death has occurred, and then we go back to do the cause of death study as a follow-on study. But also, in addition to that, what we have been doing is at the time of listing, when we have the income expenditure survey, we usually have sample sizes of, had a sample size of about 16,000 households, almost 1,600 enumeration areas. Now, in each of these enumeration areas, we would add a question as to whether there was a death in the household, so that we are able to capture, to get a fairly large sample for, the households where a death occurred, and then a follow-up study specifically targeting those households is undertaken. Now, that's one way of trying to capture some of this information that would easily be missed when you use the traditional of selecting the 10 households that you select per cluster, and your chances of missing out deaths is higher. So because it's a rare event, that's what we have been trying to do, and probably we've been thinking of how can we capture this. But also what we are trying to do now is, as a government, there is an initiative to revitalize and actually to operationalize the vital registration. And here I call it community information system, where there is reporting on certain events at community level. And so as a bureau, we are going to start receiving this information. So there is an investment that we are doing into this, but the idea is eventually we should be able to capture as much information as possible. And as to whether we will be able to sustain it over time, that's another issue, but the spirit is willing and the commitment is there. Thank you.
Okay, thank you, James. And last, I'll put this question to Etienne. So we've seen how objectives in terms of sample size were set in DHS and mixed surveys, but I wanted to ask you how MSF typically sets out objectives for mortality measurements from household surveys that you might conduct. And if, in your case, besides funding, there might be other constraints to the conduct of larger mortality surveys in the settings where you usually work.
So we are working on crisis. And so if we do a mortality survey, is to assess the severity of a crisis and to identify the main cause of death. So that's why we always target, we have a short recall period. And so we use a direct report of mortality among households. And we didn't find, I mean, when we use, for instance, for the pre-pandemic estimate that we have are below the expected mortality in this setting. So we didn't find an overestimation of this method. So normally we design our sample size exactly on that to be able to detect a substantial excess mortality during a crisis, a substantial excess mortality on what we can address. And in this particular case of COVID, in fact, we design our sample size on the expected increase in mortality among the people over 50, because it's we assume that we're the people that will be the most affected by the pandemic. And so we decided to have something significant, and it's what we find in 4 out of the 5 surveys. We find a significant increase in mortality in the over 50. After the size of the sample, what we want is to use our resource wisely, to not spend our resource for nothing. So we design our sample just to be able, to reach our objective, and after to have an action to take with MSF in order to help this population. Thank you.
Okay, thank you, Etienne. And so now to our final round of questions, which will be a lot more open-ended in that case, where I think we will go around the panel asking your thoughts as practitioners and experts or users of such surveys. In thinking about upcoming surveys in settings where household surveys are the primary or an important source of data on mortality, what do you think might be a couple of possible innovations in sampling that would enhance our ability to measure the toll of the COVID-19 pandemic in contexts where we don't necessarily have all the civil registration data that we might like, or other statistical systems that generate data on mortality. So let me first turn to Sinan to ask for your thoughts about this, and then we'll go to each of the panelists.
Thank you, Stefan. Of course, it's very challenging, and according to my knowledge, so we don't have very innovative things coming. But on the other hand, it's really depending on the country and also the frame availability. So if the country is developing and the mortality is high, but then the resources like the sample frame or the census frame is challenging. So there might be some other use, as Etienne mentioned about. So some other sources like grid sampling or some the aerial imagery, but we need some external support for this. So I've been thinking before your question. So what if we can get even some external data, not for the whole country, but some selected enumeration areas or some census areas, so that we can combine in advance, or we can kind of contact with local governments. So if they somehow keeping some records, like funeral records or cemetery records, then somehow we can increase the selection of the units, like households or dwellings with this disease, the members. So this can be a way, but what we need to examine and experiment this, because if the country already developed, the mortality is low, but on the other hand, they have resources and they have the registration system so that we can get the information. So I don't know. So but the combining this the small area level or local level registers might be an innovative idea to discuss. It's really worth to discuss, I believe. So at this moment, this is the thing that coming my mind. So over.
Thank you, Sinan. So, James, I would like to ask you the same questions. If you think of possible innovations or modifications that might help us.
Quite, as indicated, is quite challenging. But you know, I was from our end, because we have been doing a number of surveys, coming in every year, 3, 4, 5 surveys. And what came to my mind is that since we are drawing from the same frame, and we are able to capture some information from each of these the households, and these surveys, we ask 1 or 2 questions about mortality in all of these. I believe as when we combine all this, we can be able to tell a story about what's happening. Of course, there could be some issues on how to do this, but I believe I'm just thinking about existing investments in surveys and how we can piggyback on them to include questions that are common across the different surveys that are undertaken. Because as a bureau, all national or official surveys come through the NSO, the Bureau of Studies. So we can add a question or 2 without, and the funder will not have a question. And so the issue is, if there is this data gap that we need to close, I think it's important that we include some of these, because it's for the interest of all of us. It's not a selfish interest, but you realize that there is an opportunity to fill a data gap, which is not so easy to close. But also what we have tried to do is, whenever we have large surveys and we have an opportunity of listing, I think we try to include them at the listing stage and then be able to see crudely what is happening. Of course, with the death, it brings a lot of sentiments to people. Some may not want to talk about a death, depending on actually the person they lost, so they may decide to keep quiet. But you can assume that is random. And depending on how consistent it is, I think all the same, I think it should be able to give you some idea. Otherwise, in surveys increasingly, you need a very huge sample to be able to get some bit of information on the mortality. But if you exploit every opportunity that comes to the National Statistical Office, and eventually you try to see how to combine all these, to me, I think we can be able to benefit from that kind of approach.
Terrific. Thank you, James. So, well, same question. Etienne, maybe you want to go next?
Or what would be the innovation? So for us, I mean, our question was first to see if the virus was circulating, and that is definitely shown. But so the excess mortality, we did observe that in at least 4 out of our 5 survey. But directly link with the disease is difficult. So what we have shown is that there is an effect of the pandemic. Where I think we could improve, as I mentioned before, I think that the recapture, or other source of data to try to triangulate could be very interesting. For instance, what they did in the morgues in Zambia, where they did test the body to check for the virus, was really interesting and show a much higher impact of the pandemic than expected. Yeah, I think that's mainly that, try to triangulate, have many sources of data and use, and if possible, use this recapture approach. I don't know if the audience is familiar with, but this is quite difficult because you need an identifier to match the different patient case in the sources. That's my main suggestion, but I'm sure there's plenty of other ideas to improve.
Thank you, Etienne. Hoi, do you want to weigh in?
Thank you so much. I hear a lot of new ideas since I'm working on the agenda for the expert group meeting. So definitely, as every panelist have mentioned about triangulating data integration, really either at the frame level, putting different frames together, or the data level when data are collected. I think that would be super important. And for our group as moving forward, I would like to add a question instead of adding more innovative approaches. Is I've heard about the, what is it called, absolutely no data or very little data for certain age groups for adult mortality. So can we as a group think about what exactly we're trying to achieve with surveys, what age group that we're focusing on, what other demographic characteristics that we're interested in having, and also at what level of geographic area, whether it's national, are we okay with national level monitoring, or we would like to go a bit deeper, lower than that, and how often do we want the data to be available? And we will have a list of target countries to work with, right? Because those are the countries that do not have CRVS. Those are countries that the tag, large tag group that weren't able to get data for the excess mortality estimation. So we have a list of target countries, but if we can specify the data needs, I think that would be giving us a little bit more the target, what we can work on. Definitely capture, I love that. So our colleagues from UN-DESA has been using that method for trafficking, human trafficking, because you can't see them at all. It's been challenging because it's also very political sensitive, but then I've seen a lot of work around that area as well. We'll definitely be able to bring them in if that's something we would like to work towards. Thank you.
Okay, thank you. And so last, Jeff, you get the final sets of thoughts on these possible innovations before we open the floor to questions.
Thanks very much. My notes on this were somewhat similar to Sinan's comments, actually. I think that in broad terms, not necessarily specifically for COVID, but I think benefits for COVID as well as, I think we ought to think about changing the perspective of our household surveys as an independent monolithic activity that gives us a single answer to our questions, and view it more as an embedded surveillance activity within the broader health data surveillance and CRVS infrastructure that's being built up. And so I think that the implication of that for surveys is much more linkage with routine health system data and questions that allow us to link what we're seeing in a survey with health system data. So for example, asking, did the deceased attend hospital? Before death, did they die in hospital? That would allow us to triangulate with, if we're better at capturing hospital deaths than non-hospital deaths. And so I think that'll allow us to, one, triangulate and squeeze more out of survey data by linking it to other sources. It also makes our surveys a tool to monitor the implementation and effectiveness of the routine surveillance that we're building. So to know when can we transition to primarily using our routine health system surveillance and not be so reliant on surveys. But also, as we work towards that objective, we use the surveys to right size and extrapolate our routine estimate, our routine data estimates and trends, rather than just waiting every 5 years to get a new survey. I think also, just to note, I think that a lot of the work that MSF have done very rapidly during COVID is a good example that we should build on for other disease interests. And I think, as always, crises bring innovation, and now it's a matter of learning from that for, you know, the slow-moving beast that is HIV, for example. And I think that the last just one thought I had about this, or caution, is as we're innovating and using more routine data, make sure that we don't cut corners on robust design and sampling frame of surveys. I think that within HIV, we have seen some of that in an effort to do more efficient or cheaper surveys or reach hard to reach populations, but we end up with a lot of data, spending a lot of money on data that it becomes very difficult to interpret and reference. And so let's make sure that let's innovate, but also stay true to robust design as we do that.
Thank you. And so on these words of wisdom here, I would like to take this opportunity first to thank the presenters and panelists for your insights and thoughts and suggestions about how to think about sampling for household survey in the context of COVID-19 pandemic. That was extremely helpful. And so now I want to give a chance to members of the audience to ask questions if they would like. We have another 8 minutes remaining, potentially a little bit more for those of you who want to stick around. So we can do this a couple of ways. So you can either raise your hands and speak up, or I can relay questions that have appeared in the chat. So let me first start maybe with a question from the chat, and then if in the meantime hands appear, we can go that route. So the first question is from Ariel Karlinski, who asks, how can survey-based mortality estimates, especially during COVID, be validated in countries with lacking vital registration? So who would like to take this among the panel?
I can answer.
Yeah.
So it's really challenging. It's not so easy, but first of all, we can kind of validate the estimates from the sampling error perspective, so that first of all, we can just look. But on the other hand, we also have kind of model-based the estimates for the countries with a working group. So I mean, at least we can just compare with the previous the mortality levels, and we can compare similar countries. But there's no, of course, proper poor way of comparing without having a vital registration. But on the other hand, we have to be also careful about the vital registration systems. In some cases, we also see some coverage or freshness issues on vital registration too. Thanks.
Okay, thank you. Yeah, Jeff, you want to add?
I might also comment on this, and that this has been a major challenge for HIV, and there are a lot of uncertainty about the interpretation of sibling history mortality data and potential biases, and so this has been a challenge for HIV as well. And I think that this is an area where leveraging models as a tool for data triangulation becomes really important. And so so seeing that we see not only a plausible estimate, but that the signature of a pattern that we see from surveys is consistent with what we would expect for other data from other data sources. So in the case of HIV, age patterns and trends in prevalence over time and the expected disease progression that would result in deaths. And this is an area where I know that one of my colleagues here at Imperial, OJ Watson's, worked a lot with MSF on and finding very similar things, that not only are the results of the MSF surveys very strong, but also they have a lot of internal consistency between the epidemic dynamics that are suggested from the seroprevalence data with the signatures of the mortality patterns. And so that lends credibility to both of those.
Terrific. Thank you. So next we have a question from Afshin Ashofte. I hope I'm not mispronouncing this too badly. But the question is about mixed mode effects during the COVID-19 pandemic, as you know, and as was discussed during the panel. New modes of interviewing were frequently introduced by country, including computer-assisted telephone interviews or web interviewing. And so in that context, what could be recommended as the best practice for controlling these mixed mode effects in surveys? And is there any recommendation or experience for dealing with this, estimating the new weights and coverage errors, and issues of questionnaire design? Anyone? Or
I'll be
yes,
happy to respond. So as I
Please.
mentioned, we have a new guidance book coming out and really assessing the quality, and mode effect is one of the key aspects that's been covered, both in terms of representativeness and also in terms of measurement errors. Because as mentioned in the question, when you cannot ask the same exact question for telephone, in-person, face-to-face, or web survey. They have to be adapted, but you need to test the equivalence, whether they are the same question. There's also a book that was most recently published called Mixed Mode Surveys by Statistical Netherlands. So we are inviting them for a webinar in November this year. So please look forward to that. We'll send an announcement. But one of the key challenges is it might work for Netherlands. It worked for one country, but you will have to test it. It will be very different in your own country perspective. So we have been recommending a lot of experimentation and not just take the result as is, because you would really have to work within the own context and try to integrate smaller experiments in any large survey data collection activities. The other thing about mixed mode is if it's sequential, like if you go with the cheapest one and move on to more expensive one, it's actually it's a logistic nightmare that has been bothering countries. And it's not just the mode effect, it's more than that. How do you organize the field work? It's very challenging. So we're sort of thinking whether we should provide guidance in certain aspects, but it's pretty new field. Thank you for asking the question. If anyone's interested in reviewing, providing input in our new guidance note on assessing quality and reduce the bias of surveys carried out during COVID, please let me know. Thank you.
Okay, thank you. And so final question I can see in the chat asks about, again, the links with death registration. And if the coverage of the death registration or the completeness of death registration can be measured from surveys, and if reports can be required to detail on this indicator as well. So that's a question for you guys.
Maybe I can, I mean,
yeah.
If I understand correctly the question, during our survey, we normally ask, so if the death had a death certificate, if the family has a death certificate, and try to see the percentage of people of deaths that have been registered. And normally it's in our field it's quite low, suggesting that death registration is really poor estimate of the actual mortality. Not sure it answers the question.
But DHS and Mix, please add that question urgently.
Yeah, I would echo that call as well. And it's one question we've been trying to add in surveys and in validation of some of the different mortality questionnaire, from household deaths to siblings data to parental survival history, and it doesn't generate much missing data or don't know answers, and it yields estimates of completeness that are fairly in line with what's expected, at least, but they help you also look for differences in coverage between groups within the population, which is particularly helpful. So yes, same cry from the heart as Jeff just expressed from me as well. I don't see other questions unless somebody wants to speak up and ask questions, or put them in the chat. I'll give it another few seconds. Going once, going twice. No. Okay, so then in that case, we're going to conclude this this webinar here right on time, which is a first from our end, I would say. But I want to again thank all the panelists for their contribution. Thank the attendees for taking the time to join this webinar and contribute your questions and insight. I want to encourage you to contact us if there are any follow-up thoughts or ideas that come up from this discussion. I believe the webinar will be posted online at some point, so it can be shared as well. And we'll advertise some of our future activities so that you can join us again if they might be of interest. Okay, and I don't know if people at the Secretariat have anything to add. Otherwise, we'll close here.
I don't have anything. I don't know whether my colleagues, Miriam and Cheryl, has to leave early, but whether there's anything. But thank you so much, everyone. It gives a lot of insightful information for us to move forward.
All right. Thank you, everyone, and have a great rest of the day.
Thank you.
Thank you.
Thank you. Bye bye.
Thank you.
Bye.